Hi, everybody. This is Professor Alex, and I will be going through Chapter 19 on health and illness with you today. No intro. I'm going to try to get through this as quick as possible because I know recording can be hard to sit through. But at the same time, this chapter is dense and there is a lot of material to be covered. So let's see what we can do. So again, it's Chapter 19, health and medicine or health and illness. In terms of sociology, medical sociology is a popular and prominent field within sociology. Some other tracks, for example, if you go to grad school, might be medical sociology, social inequality, might be race and ethnicity, or like sex and feminism. But medical sociology tends to be a particularly applicable field in terms of trying to get a job, especially within the healthcare field, a hospital, etc. In terms of defining um, health and illness, of course, end up being social constructs, right? And the way that we respond to different health and illnesses or lack of health and prevalence of illnesses is also a social construct, the way that we respond to death. All of these things are dependent on the society that you live in terms of context. In terms of sociology, a big aspect when we look at health is, again, we are not blaming the individuals, right? A psychologist might look at kind of what's going on within the individual on a biochemical, psychosocial level, but sociologists are more so putting the blame on our society, right? So whereas one person might be like, oh, like, I don't know, why are you obese? In sociology, we look at what's going on in our society where so many of the people in our society are struggling with obesity, right? Is that an individual thing? Or since there's so many people that struggle with that, might that be an indicator that there's something wrong with our society? So sociologists are more so going to look at health from that perspective, from what's going on in our society that's causing this to be so prevalent. Um, in terms of determinants of health, sociologists look at these things especially. So economic stability, neighborhood and physical environment, education, resources, food, quality of food, community and social context, as well as healthcare system and access to healthcare. So these are more social aspects when it comes to health rather than just kind of what other people might look at as like a biochemical side. Sociologists look at these kind of factors. In terms of measuring pain, this is what the slides provided, which I think is oversimplified, right? This is a popular pain scale. Every time that I go into a hospital, I do see this scale. It's very popular. But I did take a rehabilitative psychology course, and he wanted to emphasize how many different types of pain there are, right? Is it a widespread pain, a centralized pain? Is it tiring, throbbing, tight, stabbing, aching, burning, intense, mild? Is it a spasm? Is it pulsive? There's all sorts of, like pinpricks, bone drilling, white blinding pain. There's a lot of different types of pain. And that's something that a psychologist or a sociologist might look at. In terms of global health, I think it's really important to compare how the US is doing to other countries. And I'll try to get into some specific examples as we go through the lecture. I do want to talk about culture-bound syndromes. This tends to be really interesting. Culture-bound syndromes is a illness or syndrome that is quite literally bound to the culture. It is only relevant in that culture. I will say that I'm posting this lecture late because I had to relearn a lot of things here. So in terms of this first note, prevalence of ADHD eating disorders is much higher in the US. With my research today, I found that neither of those statements are true, and I will walk you through some of the statistics on that. But as for some other popular culture-bound syndromes, we have the idea of jinns in Afghanistan and Pakistan. A jinn is kind of, you can think of it as like an evil spirit that might attach to you. I think we're all familiar with the evil eye. Um, some more interesting ones are dot syndrome, which you can look up, which is the fear of losing semen, which is within the cultural context makes a lot of sense because they consider semen to be connected to energy, right? So they're like, if you expel semen, you lose energy. So that might translate into a more extreme fear of losing semen, in that you might fear that it's taking your energy. There's other things that you can look up, such as brain fag syndrome, ghost sickness. I won't even try to pronounce that one. But I remember my professor talking about this one, where it's like when someone struggles to confront their anger, um, specifically regarding injustice, which I think is particularly interesting. And so sometimes they might lash out in an extreme way, um, which I think is, I'm sorry, kind of interesting, because typically when we lash out in the US, it's due to some individualistic reason. So I think it's interesting that this is tied to more so social and structural injustice in that culture. There's also Coro syndrome, which was a really interesting syndrome. Apologies, I don't know how to edit videos. But Coro syndrome was one that I remember I was particularly interested in undergrad, where it kind of is this hive mind mentality type situation where this group of people had this fear that their penis was shrinking. And how this kind of can happen is one person wakes up and they're like, oh my God, my penis is smaller. What the hell? Right? And then they go to their neighbor and they're like, I woke up and my penis was smaller. Is your penis the same size? And then the guy might be like, wait, let me go check. And then he goes and checks and he's like, wait, no, mine's smaller too. And then they start go asking their friends, right? They're like, yo, what's up? Like, I think my dick shrunk overnight. Like, what's up with, like, is yours good? Like, what's going on? And then people get anxious and they're like, oh my God, no, me too. What the hell? And so what happened was they sent doctors over to these communities to actually go in and physically measure the length of their penis. I think it was like once a month for about a year, to show them statistically, numerically, that your dick is the same size. It's been the same size all year. It hasn't got smaller, hasn't got bigger. Everything's cool. But it's something so mental where even looking at the facts, you still believe something else, which is quite common, right? So kind of this hive mind, what a hive mentality type situation where this anxiety over a shrinking body appendage might spread throughout the community and become so prevalent that doctors need to be sent in. Um, so other examples, amok, this is when people are, I've heard like different stories about how this might happen. I actually won't even try to explain it. I would just encourage you to Google it because I wouldn't be the best one to explain it. Um, and then also susto, like the fear that your soul has left your body. And, you know, again, I challenge you in sociology. We're not like, oh my God, that's so crazy, right? It's more so, oof, if I was in that situation and I felt like my soul had left my body, I would be absolutely terrified. So I definitely sympathize. Not that I understand, but I definitely like sympathize with that. So if you are interested in any of these, I definitely encourage you to look them up. And then off of that, I wanted to, you know, I had to do some research into a couple things where I have to admit where I was wrong. As you see here, I had thought and I was taught that ADHD and eating disorders were culture-bound syndromes to the US. And I will admit I have been teaching that up until right now. But with some research, I found that neither of those things are true. So ADHD, I'm not going to really explain it to you. That's something that you can kind of like look up. Um, but this is something that was previously thought to be a culture-bound syndrome to the US. But after further research and more recent research, we found that it is not culture-bound to the US. It is very prevalent in the US, as you can see here. This 2018 source says 9% of US children, 4% of US adults. And this source over here, I think this was 2021, but you can double check, 1 in 20 children in the USA. So it's incredibly prevalent in the US, but it is not a culture-bound syndrome as I had thought. I do have linked here a prevalence map that is interactive. Here is a screenshot of that map, but you can kind of go in and play with it and get more information. You can see here that US has a high prevalence, but it's not necessarily the highest. I was actually interested in the Australia situation here, and I didn't have time to go read into that, but that would be something interesting to maybe reflect on in terms of why does Australia have the highest share of population with attention deficit. Another map here to kind of more clearly show some numbers. You can see that the US has 8.1% of the population with ADHD, whereas compared to, I wish they put Australia in here, but they didn't. But you can make some comparisons, and there's also this link here to go play with this interactive map. Another thing that I thought was a culture-bound syndrome to the US was eating disorders. This is what I was taught in undergrad, so maybe it was for a minute, but newer research has shown that that is not true. Again, this is something that I am just learning as of today. Things are always updated. There's always new resources. There's always new research, and you gotta stay updated on it, right? I'm not gonna read all of these to you. I did post the updated PowerPoint to the file section, but most concisely, what's been found is that BN is is that bulimia or a binge eating disorder? Ooh, I'm so sorry. You're gonna have to go in. I don't know what I kind of copied and pasted a lower part of the article. Let me do it right now. Okay. AN is anorexia nervosa, and then BN is bulimia nervosa. Okay, cool. So not cool, but you know what I mean. So what more recent research has found is that bulimia nervosa is culture bound to the US, but anorexia is not. Um, they're saying heritability. That's another question. I haven't even read into the heritability of bulimia and anorexia. I was just taught that it was very particular to the US, but I've found that that has since expanded globally, particularly anorexia, but not quite bulimia. Bulimia might still be culture bound to the US. Another thing that would be interesting to reflect on. I do have another interactive prevalence map here if you would like to look at that. A screenshot is here. And this is an example of why it's important to look at different types of maps. So for example, this here is eating disorder prevalence in 2019. So this is the share of people with eating disorders, right? So that's prevalence. And then this is number of people with an eating disorder. Prevalence would actually be a more a better statistic to use than actual number of people, because number of people doesn't end up being relevant to the actual population, how many people live in that country. So you can see that we have a lot of people with eating disorders in the US, but in terms of prevalence, we're not the highest, but we're definitely in the middle. We're not the lowest either. I still would consider there to be cultural aspects to both of those things. In terms of US health, there is disparities by race, gender, income, socioeconomic, everything, right? Disability, mental health, whatever. I don't really need to get into that. There's inequality on all levels. Um, there's always going to be the, privileged and then like oppressed identities. So when it comes to sex, males are privileged and females are not. When it comes to race, white people are privileged, everybody else is not. And all of these kind of privileged identities and oppressed identities, all of these things are reflected in the trends when it comes to health. I would encourage you to choose any health issue that you're interested in and start looking at the breakdown of the demographics when it comes to people in the US. We usually look at mortality and morbidity. Um, Mortality, this is funny, I'm trying to recall right now. I have to do this every time. Mortality, I remember because I watched the Hercules cartoon as a kid, and they were trying to turn Hercules mortal, which means human, alive, able to die. As a mortal, you are able to die. If you are immortal, you are not able to die. So mortality is related to death, whereas morbidity is related to the rate at which people catch diseases. Okay, so mortality, this is the rate of death. Morbidity is the rate at which people catch diseases or whatever. So, for example, if you look at the US during COVID, we see that people of color have higher morbidity and mortality rates. I would definitely encourage you. I probably have some charts here later on. I don't know. I would definitely encourage you to look at some COVID charts, and you can definitely see how oppressed populations just turned out worse. Another important concept in sociology is deprivation amplification. This kind of refers to how when somebody already has risks, let's think nature versus nurture, right? Let's say that somebody via nature already has predisposed risks, right? And so nature, that's genetics, that's biological, whatever that might be, neurodivergencies, this might be a physical disability, this might be um, being Black or being Hispanic or being anything but white, right? Already having these identities that are oppressed, and then like by nurture, and then by nature, the already existing, hereditary, genetic, biological diseases or issues are being made worse by environmental factors, by nurture type factors, right? So, oh my God, you're already, a person of color who's a woman who has ADHD and autism. So you're already by nurture oppressed. And then let's say by nature, you live in an area where there's a lot of people who live in one building or one apartment. You live in an area where there's no green spaces. There's nowhere for you to go walk and enjoy nature. There's been a lot of studies that say that people who have more access to green spaces have better health outcomes. I definitely encourage you to reflect on that. And then further, those studies typically find that white people have more access to green spaces than do people of color. And we see often that we tear down green spaces in minority communities and replace them with some sort of gentrified building, right? So I won't get too far into this. I guess I'll stop with, I think the more important thing would be to focus in on green spaces. I think it would be interesting if you did a reflection on what is the impact of green spaces on health, who tends to get those benefits, and who tends to be deprived of those benefits. Maybe even looking at PG or looking at DC and looking at how many green spaces are west of the Anacostia versus east of the Anacostia. Green spaces have a big impact on health and are not talked about often. But yeah, I use here food apartheid as an example, which we already talked about in class. But let's say that you already have, I don't know, high blood pressure, and then you don't have access, or, maybe you have quote unquote access to a grocery store like 2 miles away. But like, what if you don't have a car, right? Or like you have to take the bus to the grocery store and you have to get maybe the most essentials. or you have to get things that travel okay. But for example, it's like not everybody has a bus to get to the grocery store. People also tend to look at, oh, does this community have access to safe sidewalks to get to a convenience or grocery store? So there's a lot of aspects that go into kind of like access to grocery stores in terms of how can people get there? Is there public transit? Is the public transit affordable? And is there a space within a few miles? And does that space have access to fresh veggies? And so, for example, I put that here because if you have a hard time accessing fresh food, then that's going to impact the rest of your health in terms of heart disease, hypertension, obesity, diabetes, whatever. And so for me, like as a sociologist, when I see these things, my automatic response is not, oh my God, that person's unhealthy. Oh my God, that person must eat so much. Oh my God, that person must, eat too much fast food. My reaction is, oh my God, what is wrong with our society where this is like the go-to, right? Where people don't have access to fresh food, and therefore have to lean towards quicker options. Another thing to consider is that even if someone does have access to, let's say, like ingredients to like cook for dinner, um, what if that person has two jobs or multiple jobs or multiple people in the family are working and there's nobody around who can cook, right? If you're working a lot and you come home, the last thing you want to do is cook a meal for the whole family, right? And that job is typically put on women. Um, if I were in that position and I came home from like working all day as the breadwinner, which I am, and then someone was like, "Oh my God, you have to make food for the kids." I'd be like, "Kids, get in the car. We're going to Burger King." Like, I'm not cooking, right? So there's also like the consideration of, okay, maybe there's a grocery store nearby, but does that mean that that family has time to be cooking a healthy meal every night? That's ridiculous. I don't even cook for myself every night. No. Um, we've talked about this pretty much just, I mean, really all types of illnesses, you're going to find some sort of social inequality, whether that's by race, sex, gender, SES, whatever, geographic location, wealth. Um, we see racial, sex, gender disparities up and down the board always. One of the more interesting cases to me and to most of my students, I have a lot of students who go into nursing for this reason, is US fetal and maternal morbidity and mortality rates. So again, let's say I'm pregnant and I go into a hospital to give birth. There is the maternal, me, the mom, the maternal morbidity and mortality rate, and then there's the infant that I give birth to, the infant mortality and morbidity rate. So when you look into these numbers, they're kind of broken up into a few different sectors, right? You can look at the maternal, the mother, their morbidity rate of catching disease and mortality rate of death rate. And then you can also look at the infant morbidity rate of catching disease and mortality rate of death rates. They're all very interesting to look at. And then especially if you want to dig deeper and look at women who are incarcerated and their child's maternal and infant morbidity and mortality rate, it just keeps getting worse, okay? But the reality is that overall, we do a really bad job with infant and maternal morbidity and mortality when you compare us to other countries. And I'm not even talking about race demographics yet. As a country, we do not do well compared to other developed industrialized countries when it comes to maternal and infant morbidity and mortality rates. And then when you break it down into race and ethnicity, it gets worse, right? And then when you break it down into socioeconomic status, it gets worse. So we can see here, what do I have? Infant mortality rates by race and ethnicity 2019. You can see that non-Hispanic Blacks have the highest infant mortality rate. So if they go to give birth, their infants are most likely to die. Here we have what? Oh, damn. This is by this is by income. So lowest income counties is this red. Let's focus on this. Lowest income counties is this red line here. So although it's not necessarily way higher than the others, we can see that this red is pretty consistently higher than the rest. So even down to income. Um, I guess something I should mention is that when it comes to any illness or disease, let's say that you are a woman of color. Okay, let's say I go in. I was like, hey, that's me. Let's say I go into a doctor's office. The reality is due to implicit bias. Again, not that the doctor is like, oh my God, you're a woman of color, I hate you. But due to implicit bias, due to what we've learned, what we've been socialized to know about people and kind of stereotype and generalize, what happens is that me going in as a woman of color, if I'm seeking help for anything, um, what will happen, like statistically, is that doctors will not offer me, not even offer me the best option because they will assume that I cannot afford it. This happens a lot where we have, let's say, Black families go in for treatment for their child and they're not even offered some of the better options because people assume that they don't make any money due to their race, which if you go look at, if you want to go Google it, there's more poor white people in the US than poor Black people. Is this due to the fact that there are more white people in the US? Yes, but statistically, if we were to look at someone of a race and assume that they were poor, statistically it would be white people. Okay, so it's racist. It's racist. But again, implicitly racist, not necessarily explicit. It might be something that they were kind of low-key taught, where they were like, hey, maybe some of their higher ups who are older and outdated might be like, hey, be careful about, not offering certain treatment options to people who can't afford them. But honestly, if that's how you were trained, like that's bad. You should be offering all options to everybody, and then they can make an educated decision about what they want to choose, right? But the reality is people will not even offer certain options to certain people if based on judgments about them not being able to afford it. So when we look at maternal mortality rates, this is the deaths of mothers while giving birth. We see that Black women have substantially higher maternal mortality rates, and this is why I think a lot of women of color are hesitant about going to hospitals and lean towards alternative measures or even having a midwife. But of course, those things are expensive. And again, this isn't due to explicit bias where doctors are like, oh my God, I hate Black women. It's more so an implicit bias, this ingrained kind of subconscious bias that we have against certain people that causes us to treat them in a more negative way. But as a doctor, again, I think it's your responsibility to be aware of your biases and be aware of the statistics like this, and therefore consciously go against them, right? Like if you're a doctor, you know this stat, you know that women of color are more likely to die giving birth. So as a doctor, I would hope that you would be like, wow, oh my gosh, this is a woman of color. I best give her extra attention due to the fact that statistically she's more likely to die giving birth, right? Let's use these stats to grow stronger. Um, so whatever, these are some more stats that you can look at. So this is like the US compared to other countries. This is maternal deaths per 100,000 live births. You see that for the US, we're at about 17. And the next country after us is France at about 9. So again, not shitting on the US, But if we do love our country and care for our country and want to be proud of our country, then we want to push it forward. And this would be a great area to start. Yeah. So then, I'm like, well, I wanted to give you something positive, right? So like, are we getting better with science and experience? Um, no, nope, no, we're not. No, we're not. So you can see here that pregnancy related mortality from 1987 to 2015 has steadily gone up. So when we look at these numbers, it's not like, oh, well, we're just trying to find the science. Babe, go ask France. Go ask France what they're doing and copy it because they have half the deaths that we do. Like it's been established. We have countries where it's been established, where they have an established low maternal mortality rate. We could swallow our pride and go ask them for some help. You know what I mean? That's all. There's other countries who are doing it better. Doesn't mean that we suck, means that we could do better. Yeah. So this all goes into cultural competence. So for example, going back to exactly the slide here where I said, so for example, if I'm a doctor or a nurse and I'm going into natal care, child care, like if I know that I'm going into a field where I'm going to deliver babies, then I best be familiar with these stats. And then with these stats, again, I want to combat them. Okay, that's being culturally competent. I know that Black women have the highest maternal mortality rate in the US. So what can I do to combat that and make sure that she's safe and good? That is cultural competency. Being aware of other cultures and how they may experience things or what's going on with the statistics, the morbidity, the mortality, different health trends, who's more likely to catch what. Is this genetic? Is this social? Whatever. Being aware. So, for example, if you're a doctor, let's say you're a Black doctor, but then somebody comes in who is Asian, right? Being aware that diseases may show up on them differently, or they might kind of communicate them differently than people of other races or ethnicities or geographic locations or socioeconomic statuses, right? We are not a monolith. We have all sorts of different identities that are overlapping that we need to be aware of, especially as a teacher or a doctor or someone in a position to make, decisions. You have to be culturally competent. Just understanding, being aware, and being willing to learn that other people have different experiences or whatever. You understand what I'm saying? I have a couple cute slides here on cultural competency. What does it say? Nursing. A culturally competent nurse may inquire about a patient's preferred pronouns and use them accordingly. A culturally competent teacher may incorporate diverse perspectives into their curriculum to foster a more inclusive and enriching learning experience, right? But this is something that my mom, as like an HR, human resources VP, uses. Like she encourages cultural proficiency, and she kind of talks about cultural competency as a kind of process, which is something that I didn't really think of until she brought that up. So from a human resources perspective, when you train your people within your company, you might use this kind of continuum as my mom does. Further info. Okay, mental health. I can't get all into mental health, but again, looking into, and I can't do all of this for you, but looking into discrepancies in mental health in terms of race, sex, geographic region, and socioeconomic status. But also being aware that when we look at stats when it comes to neurodivergencies or mental health, the stats are going to be off. Assume the stats are going to be off. Because let's say that the stats say that, just throwing things, let's say that, let's actually use a real stat. Let me see. 16.5% of children aged 6 to 17 experience mental health illness or disorder. So then what about the kids who don't have the money or the resources or the time or the parents who care to take them to a mental health specialist? They're not being counted, right? There's a lot of parents who just don't care, who don't notice. The kid never notices. It doesn't matter. They don't have money. They don't have resources. They don't have access. So for me, when I see, oh, 16.5% of children have mental health disorder, I'm like, okay, so 20%? Just guessing, just a ballpark, but I would guess maybe 20. But give me 1 second. Bathroom break. Okay, sorry. Hopefully you can just fast forward through that. Um, of course, despite like whatever numbers we have on mental illness, it's largely misunderstood, largely stigmatized. We judge a lot of mental disorders and we judge some more than others. Also, we have this, do you think people are more likely to reveal a physical or mental disorder? I think physical disorders are less stigmatized for sure. Not going to get into this, that's a psychology class. But I do want to talk about the DSM and autism. The DSM, and I am getting into psychology here, so I apologize. So if you want to skip the psych part, you can. But the DSM is the Diagnostic Statistical Manual for Mental Health, and the most recent one is the DSM-5. I want to discuss this with you a little bit so you can kind of understand mental health diagnoses. So yes, experts work on this. I would be very curious about the demographics of such experts, but I don't know the answer to that. But they update this, I think, every 10 years. I don't know if they're, excuse me, consistent on that, but about every 10 years they update it. Of course, mental health ends up on a spectrum, but the way that the DSM diagnoses things is kind of particular. So I'll explain that to you. First, before we get into kind of DSM things, I want to talk about autism. This is something that I've recently been considering, and it's funny because the way that I taught this last semester is completely different than I'm about to, because again, I just kind of updated some of my knowledge and was reading more recent research and had to correct what I knew. That happens sometimes. Sometimes you read a lot of research and it says this over and over again, but then you check back 6 years later and there's new perspectives and new research, and we have to update that. And that's the reality of teaching, I'll be honest, is I will give lectures and then like a year later, I'll be like, oh my God, I taught X, but now I know that X is really Y. And that's just the reality of life. I can't beat myself up. We just have to be vigilant about doing our own research. So what I wanted to talk about really quickly, because this has been a recent interest of mine, is autism, autism spectrum disorder, ASD. So, of course, in the name, it's a spectrum. But what's interesting to me is that I've been trying to really understand autism over the past year. I'm very familiar with Down syndrome, which has to do with the chromosome issue. But autism has been kind of debated back and forth about whether it's genetic or social. So the nature versus nurture argument is very, very relevant here. And this is like an ongoing kind of debate argument. And kind of reviewing the research prior to this is I found that there's a lot of different perspectives. There's a lot of people who feel there's a genetic component. There's a lot of people who feel that it's completely social or environmental. A lot of people who think that it's like how you're raised, contextual. A lot of people who think that it's like social and subjective. So there's been a lot of different perspectives. So let me kind of review what I found. So first of all, according to the National Institute of Health, the NIH, which is legit, they say that autism spectrum disorder, I'm just say autism. autism is characterized by deficits in social interaction, verbal and nonverbal communication, and engagement of repetitive behaviors and interests. I have this bold because like I wish if this wasn't recorded, I would make you repeat it after me, and I'll come back to this. So the CDC estimates that 1 in 54 children has autism. I'll show you later on, well, right here, the Center for Disease Control more recently has estimated 1 in 36 children. Okay. So I should really update this to 36, 1 in 36 children. So, like, just to pause there, that's really common. That's really common. That's really common. So besides the stigma, which you all are familiar with, the reality is that this is very common and is categorized by deficits in social interaction, communication, and engagement. Okay, going further with definitions of autism. It refers to a broad range of conditions characterized by challenges with social skills, behaviors, speech and communication, a condition that appears very early in childhood, varies in severity, characterized by impaired social skills, communication, and repetitive actions. These difficulties, so what I've been highlighting, what I've been like being excessive about is that it's social, communication, behavior. No one's talking about genetics here. We're talking about social skills, communication, and behavior, right? But to be diagnosed with autism, these difficulties have to interfere with someone's ability to go through life effectively, I guess, or without issue. But people with autism also have more likelihood to have depression, OCD, eating disorders, which I didn't know. But a more recent, actually, no, this is 2012, not that recent. This paper from the NIH had said, it's clear that the search for environmental factors should be reinforced. So it's just interesting because this is so random, and I've been asking other people about this, and they haven't had a similar experience, I guess. But what I was taught was that autism was people who had like less than a 75 IQ. That's what I was taught. I don't know who said that, but that's what I was taught. I always thought, like, literally up until like a year and a half ago, where I read a book from the perspective of an autistic adult, where I realized that autism has nothing to do with IQ. And then some people argue it has nothing to do with genetics, but again, I was trying to do my diligent research before this, and there are quite a few papers that do say that there's quite a few genetic elements to autism. So, I'm being honest, last semester I said there's no genetic component to autism. That's Down syndrome. I was wrong. There are some established research papers that say that changes or mutations in genes can be associated with ASD, but they found that a lot of these associations have not been confirmed. So whatever, it's definitely, when you read research, autism is a neurodevelopmental disorder, whereas Down syndrome is like a genetic disorder by categorization. Um, so I don't know, there's definitely biological aspects, like people with autism have increased gray matter in the frontal and temporal lobe. But ultimately, what I used to challenge was like, this isn't really a genetic thing. This is largely a social diagnosis where, like, again, if you go back to just like, if you Google and you go into like any reputable source, the definition of autism, you pretty much see this thing where it's like challenges with social skills, behaviors, and communication. That's very social. Autism is literally not acting the way you're supposed to in social situations, literally being deviant in the way that you communicate or behave in social situations. And so the whole thing, I'm still trying to wrap my head around it, but the reality is 1 in 36 people have an issue in social situations. So is it autism, or is it that we're just realizing that not everybody responds in social situations the way that everybody else does. And that's where it becomes, that's where the spectrum part is important, and that's where the DSM is important, because typically to be diagnosed with something, it needs to actually impact the rest of your life. So for example, you know, and I probably shouldn't do, I honestly think I have autism, but I've been diagnosed with bipolar, so I'm gonna go with what my psychiatrist says. But sometimes I think I'm autistic, and my psychiatrist says that I do have like definitely autistic like symptoms and syndromes, but it's not my ultimate diagnosis. Um, but let me go to like actually let me say what I'm trying to say. So for example, let's go into the DSM for autism. So this happens a lot, the DSM, is they'll be like, okay, there's section A, B, C, and D, and then they'll mess around and they'll be like, all right, for someone to have schizophrenia, they have to have 2 from A, 1 from B, 3 from C, and 2 from D. And it's really annoying. And that's how the DSM works, like for real, for real. So for example, you know, someone with autism currently or by history must meet criteria A, B, C, and D, right? So A is persistent deficits in social communication and social interaction across contexts. And then it has to be all 3 of the following: deficits in social emotional reciprocity, deficits in nonverbal communication, deficits in developing and maintaining friendships. Also has to be B, restrictive repetitive patterns and behavior of interest activities manifested by at least 2 of the following: stereotype and repetitive speech, excessive adherence to routines, highly restricted fixated interest, hypo or hyper reactivity to sensory input. C, symptoms must be present in early childhood, and symptoms must together limit and impair everyday functioning. This part D is like the most important part, and like you can kind of make this a generalization with the DSM, that something is not a disorder unless it limits and impairs everyday functioning, right? So for example, like let me go back to that part. But when I look at this, I'm like, okay, I feel like I have a lot of these things, but I don't have all A, B, C, and D. Okay. I have, you know, parts of each, but not enough of, you have to have A, B, C, and D. And the D part is important. You can have A, B, C, right? But if they don't impair your life, it's not a disorder, okay? You can have an issue with social, emotional reciprocity. You can have these repetitive patterns. You can stim. You can have symptoms early childhood. But if it doesn't impact your daily life, it's not a disorder. Okay. So for example, if it doesn't impact the way that you go to work, the way that you take care of yourself, the way that you interact really with other people in a negative way, it's not a disorder. So where this becomes, this was a really cool thing that I found, like a recent research paper that I just copy and pasted in here for like further research. This is like a more recent breakdown of autism. I can't go through it right now. But to like really hone in on like the DSM criteria, for example, like a thing that I hear a lot is, one second, I need to, one second. Okay. So with OCD, I hear people a lot say, oh, I have OCD. Oh, I have OCD. You can have like compulsive, you can have compulsions. Anyone can have compulsions, right? Or obsessions over things, right? But when the DSM considers it a disorder is when it impacts your daily life, and not like, oh, it's something that's annoying. Again, we're talking about like impacting work or taking care of yourself, right? So for example, let's say you leave the house and then you're like, oh my God, like I think I left my straightener on, and you go back and you check and you turn it off and you leave. and you go to work, that's not OCD, right? Or if you like leave the house and you're like, oh my God, what if I left the oven on? I hear people say this. And then you go back and check and make sure the oven's off. That's not OCD. It would be OCD if you turn off the oven, leave the house, go back to the house, make sure the oven's off, go back in your car, head to work, go back home, make sure the oven's off, head to work, and then go back home and make sure the oven's off to the point where you are consistently late for work, right? This isn't just because anybody, I think like people say, oh, I have to keep going back and checking the fire. That's normal. You should go back and make sure your straightener's on and that off or that the your stove is off. But if you do it multiple times and you're late for work often because of it, or like you're late to pick up your kid because you have a compulsion, or if you can't maintain friendships because of your compulsion, that's when you have OCD, when it literally impacts your friendships, your relationships, your work, or you taking care of yourself. My little sister will swear up and down that she has OCD because she always really liked to reorganize her room every few weeks. She was definitely like obsessive about the way that her room was set up. And she also kind of had an obsession with the upstairs bathroom door, no, the downstairs bathroom door being closed, which to me was rational because if the downstairs bathroom door was open, then you couldn't really walk through the hallway and it was annoying, right? And I do remember her being a little bit obsessive about it, about maybe her even being upstairs and coming downstairs to check to make sure that the downstairs bathroom door was closed. So I definitely see the obsession there. Like I can validate, yeah, you were a little bit obsessive there, right? But it wasn't to the point where, okay, she went to school and she was thinking about, is the downstairs bathroom door closed? That's when you have OCD. When you're like in school, at work, and you're like thinking about, oh my God, did I not close the downstairs bathroom door? Like, and it's literally preventing you from paying attention, functioning as you should in class or in work or within relationships. So anyone can be obsessive or compulsive, but unless it's impacting your daily life functioning, it doesn't matter. Same thing with autism. We can all STEM, we can all have autistic symptoms and whatever. But unless it's impacting your daily life functions, it's not a disorder. Okay. Um, yeah, so then the question, because I love talking about validity and reliability, is the DSM valid or reliable? If you Google this question, you're to find a bunch of different articles with different opinions. But let's recap. Reliability means that the test is consistent and stable in measuring what it's supposed to measure. So, for example, if you take the IQ test, every time you take the IQ test, you should get around the same IQ. That's reliable, okay? A test is reliable if it's consistent across time. Validity is if the test measures what it's supposed to measure, right? So if the test is for autism, does it actually measure for autism, right? And then another point, if a test isn't valid, then reliability doesn't matter. And if the test isn't reliable, then the validity can be questioned as well. When it comes to the DSM, the reliability and validity is questioned often. And they're good questions. It's a good question. I off the bat would say let's say validity. I don't think it's super valid. I don't like going into this, like let's say, oh, like here's the, like this is what, if you go into the DSM, the actual book, this is what it typically, not the colors, but this is what it looks like. It'll say autism, and it'll say A, B, C, D. You have to have at least A, B, C, and D, and you have to have at least 1, 2 from B, and 3 from C, and 1 from D. And it'll be kind of confusing. You'll have all these categorizations, and you have to meet at least 1 from each categorization. You have to have each, da, 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 da. It's crazy. So when it comes to validity, honestly, without getting too into it, my honest reaction is this is the best that we have. This is the best that we have. There's nothing more valid than the DSM. When it comes to diagnosing mental health, the DSM is the most valid thing that we have. But that doesn't mean that it's really valid. You know what I mean? But it's the best that we have. It is the best thing that we have when it comes to diagnosing. But do we have a long ways to go? Absolutely, absolutely. Um, I did, just so you know, like for each of these slides, I did post the updated slideshows to the Canvas. And if you go into the notes section for any of the slides, I have all of my resources. So like, for example, if you wanted to look further into this, that link is right there. If you want to look further into this, I always have my links in the bottom section here. So if you're looking into something that's not linked in the slide like that, it usually is linked down here. But okay, let me see what else we have because I need to end this. Disability. You understand disability. Long story short, we judge people who are disabled, right? And when it comes to accommodations, we are kind of iffy about it. And the only thing that I can really say here that's like relevant is PGCC versus other schools that I've worked at. So for example, and I said this in the beginning of class, um, for example, at George Washington, I pretty much get a official notification from the school with a list of pretty much the student's diagnosis and their requested accommodations. And then I sign off and I kind of approve what accommodations I can provide and which ones I can't. And I kind of sign off on it. And I'm like, yep, I know they have a disability, right? Whereas PGCC is a community college and their thought process is if a student has a disability, if they don't want to disclose that, that's fine. So we are not going to keep track or disclose or send a list of anyone's disability. If a student has a disability, they need to disclose that themselves. Because you have the ability and option to, let's say you have ADHD and you're like, but I want to see if I can do the class without any accommodations or special treatment, then you can do that. That's your choice, right? That's fine. But the reality, what's I love this in theory. I love this idea in theory. I love this idea in theory. But what I've found happens in practice is there are students with disabilities with autism or ADHD, and because it's their responsibility, they never come up to me and tell me. Like I've had a student and like, okay, I'm being just for the sake of example, I had a student a few semesters ago who was like clearly autistic, like and like deep on the spectrum, right? Like needed extra help. Like I was giving the exams and the exams were requiring 4 sentences per answer and he was giving me one. And you know, I tried a couple times to be like, imagine being a professor. I can't go up and be like, hey, do you have a disability? Hey, do you have autism? Hey, do you have a neurodivergency? Because your exam answers are reflecting something is not right, right? Because I'm sorry, the answers were like, and even the way he was writing looked childlike, like chicken scratch. And I'm not judging, like I'm like making myself sound bad, but what I'm trying to say is that to me, he was clearly autistic and like deep in the spectrum where like needed accommodations, but there was nothing I can't really go up and be like, hey, are you disabled? Or so unless you tell me I can't do anything about it. So I did my best to like grade him based on his ability, but at the end of the day, it's like I can't give you any accommodations or special treatment because you didn't come and tell me and disclose that you have a disability, so therefore I cannot treat you as such. You know, I can't treat you off a assumed disability. So I guess my problem is sometimes people who are severely disabled are disabled to the point where they can't communicate their disability. And then therefore it is detrimental to them. So I love what PGCC does in theory, but not always in practice. As for healthcare, we kind of talked about this when we talked about like, you know, capitalism, socialism. I have a couple charts here in terms of like our population in 2021. We had 66% have private insurance, 35% have public, and 8% are uninsured. In terms of the number of uninsured people, we do have that kind of going down, which is good. It's a positive trend. This is a reminder of the 2020 federal poverty line, based on the people in the household. And then you can see here that low income working adults with no children are eligible for Medicaid if their state has expanded eligibility under the Affordable Care Act. In most states, these low income adults need to make less than $17,000 per year as a one-person household to qualify for Medicaid. So this is what we were talking about earlier with the federal poverty line, where it's like, dang, if you make $20,000, now all of a sudden you don't qualify for Medicaid or public health care. And then just whatever other stats that say, if you look up how much we spend on healthcare, it's a lot. We spend a lot on healthcare, but it's funny because it just doesn't go to the right place. That's something you could kind of reflect and look for more into. But, despite our higher healthcare spending, we don't technically or generally have better health outcomes. So, and in terms of, universal healthcare, which is what we talked about, kind of with socialism, technically a socialist country would have universal healthcare as by default, but you can see here that there's a lot of countries who are not socialist or communist that have universal healthcare. So we don't have to go as far as socialism or communism to have universal healthcare, right? Like that's just something we should be able to provide. In terms of theoretical perspective, like when we look at conflict theory, look at commodification. So like this refers to changing of something that shouldn't be a commodity into a commodity. So for example, inhalers, insulin, EpiPens, these shouldn't be commodities to be purchased. These should be givens, but they're not. That's what conflict theorists will look at in terms of, medical sociology, maybe kind of commodification. Symbolic interactionist might look into medicalization and demedicalization. So medicalization is when we turn bad behavior into an illness, and demedicalization is when we turn an illness into something normal. So for example, with medicalization, ADHD may have previously just be seen as bad behavior, but now we're like, no, that's ADHD. Autism may have previously been seen as just someone who's like really weird or like non-social, and now we're like, no, that's autism. Low sex drive is kind of an interesting one. Like that might be something that's tied to a lot of other variables, but then we like give people like pills and we're like, here, and then loneliness, death. Loneliness I had just seen online, and what came to my head was like school shooter stuff. So like when someone goes and like shoots up the school, they're like, oh, well, they were just like really lonely and depressed and on 4chan and like, and it's like, oh my God, school shooter. But yeah, let's talk about how mentally ill he is. But demedicalization is the opposite, right? So for example, in 1973, homosexuality was removed from the DSM. In 1980, hysteria was removed from the DSM. Look up hysteria. Hysteria was a disease for women. So if we were like, I think you're wrong, they were like, you're hysterical. Like literally, if a woman said anything, if a woman like showed any emotion or any sort of like aggression or thought or individualism or independency, people were like, oh my God, you're hysterical. And that was like a diagnosis up until 1980. Transgender was removed in 2013. And then abortion was kind of an interesting example for medicalization and demedicalization, as we can see here in this chart, where we can see there's been like medicalization, demedicalization, medicalization, demedicalization, medicalization, kind of back and forth with abortion, right? Especially, well, yeah, a lot of back and forth with, so you can see that, some things are kind of permanently medicalized or demedicalized, and some things definitely have a kind of flow to them, right? And that is a big part of sociology, is that a lot of these things are contextual and subjective and depend on the time period and area. Please be sure to review how some of our main theories see medical issues and illness. But otherwise, this is the end of my lecture for chapter 19. I appreciate you all sticking around, and I'm excited to see you all soon. Bye.